Good afternoon, everyone. I'm Nate Allen, Vice President of Customer Success here at eVisit. Today's session is particularly special for us. In the world of customer success, we talk a lot about scaling, but few organizations have executed at scale as boldly as Pediatric Associates. They haven't just added digital tools, they have fundamentally redesigned their access model to meet patients where they are 24/7. I am thrilled to introduce our featured panelist, Greg Porco. Greg is the Director of Operations, Patient Access, and Patient Engagement for Telehealth at Pediatric Associates. Over the last few years, Greg has been a key architect in transforming their virtual brand, KidzDocNow, into a multi-state powerhouse. Today, he's going to pull back the curtain on how they scaled from a team of 7 to over 190 staff and providers using a centralized, high-efficiency approach. We're also joined by Jeff Traub, our Customer Success Manager, who will be hosting the discussion. Greg, it's been a privilege to watch this roadmap come to life. Thank you for being here to share these insights with us and the community. Jeff, Greg, I'll hand it over to you.
Hi, everyone. As Nate said, my name is Jeff Traub. I'm a Customer Success Manager here at eVisit. I am joined by Greg Porco, Director of Operations, Patient Access, and Patient Engagement for Telehealth at Pediatric Associates. Greg, do you mind introducing yourself?
Not at all. Hello, everybody. And Nate and Jeff, thanks for the warm welcome. It's definitely an honor to be here and part of this recording today and to talk a little bit about obviously how we scaled our practice here at the Pediatric Associate family of companies. I have been in this role just about 2 years now as a Director of Operations for Enterprise Telehealth. I am a kind of career healthcare professional. I've been in healthcare management, healthcare administration for 25 years. Just recently moved over from local brick and mortar practice management and administration over to operations direction for Enterprise Telehealth and our KidzDocNow brand, which is our actual name of our application that our practice operates under. We are a 24/7, 365 focused pediatric platform run all by board certified or board eligible pediatricians and APPs. We exist in multiple states right now, currently serving 24/7, 365 in Florida and Texas. We have just started our expansion into New York and Arizona, where we are starting to cover more and more hours, and we are hopeful by the end of the year to have coverage in all of our states of practice, which also include California, New Jersey, and Pennsylvania. And we have obviously leveraged the technology and the expertise of the eVisit folks to grow from something very local and Florida-centric to a national brand and a national platform. And it has been definitely an amazing journey that I have been a part of as part of our Florida market, again, in healthcare management administration, and now directing the broader enterprise telehealth platform.
Excellent. Thank you so much. Hey, so let's just jump right in and take a look at today's topics. So first, we're going to start at the beginning, life before eVisit. What tools were you using? What was missing? And we'll go into what that process looked like. We're then going to move on to ED diversion strategies. Up to 8% of virtual encounters resulted in patients avoiding unnecessary ER visits, which is just an amazing number. It's a lot of folks avoiding the ED, ER. Then we're going to look at the bunkered model. Look at how multi-state licensing and advanced analytics allowed the practice to scale from 77 providers to up to 196 plus providers and staff. Amazing scaling, and it sounds like I'm excited to hear more about how what you're looking at from an expansion standpoint. But the scale has been pretty amazing. We're then going to look at combating burnout. A very, very real issue here, especially in the virtual world. How eliminating overnight calls through virtual after hours care improved clinician retention and recruitment. And then last but certainly not least, something a little more granular, recouping left without being seen, recovering missed appointments and lowering wait times. It's so important to not just once you get patients into a call or into a visit and scheduled, but keeping them there, seeing them, and then completing the visit. So really excited about that. So without further ado, let's jump in and look at life before eVisit, called LBE. So time machine me back 5 or 6 years, Greg. What did your first efforts look like for digital care? Did you do this in-house? Where did that first iteration come up short? And what were some of the problems you were looking to solve when you started looking at other solutions? And I do have a bonus question here, and I did give you a heads up that this was coming, so which is good. But if you knowing what you know now, if you could go back in time, what would you what would you tell, well, after you bought a Powerball ticket, if you could go back in time, but what would you tell the implementation team when they were implementing the solution? What were some of the challenges that you could avoid, or what advice would you give them? That was a lot of lead up. So let's, yeah, life before eVisit, I think, is what we're getting at here.
Okay. All right. So yeah, a lot to unpack from this series of questions here. But going back 5 and 6 years, I think everybody remembers what was going on during 2020 and 2021 was the COVID pandemic. Really accelerated the utilization of telemedicine. It thrusted it into a sort of a need now instead of kind of like a sideshow type environment that I think telemedicine existed in previously, where we definitely obviously wanted to meet patients at access points where it was valuable to them. But certainly once, people were being asked to stay home and to keep their coughs and sneezes to themselves, telemedicine really became a viable product for everyone to use, especially for low acuity care and the type of stuff that we really see in the pediatric space more and more, which is essentially a tremendous amount of viral upper respiratory infections. So going back, clearly at that point, we were pressure testing everything that we had done prior to that point in time. And volume obviously spiked very quickly. So not, again, that I don't think anybody could have foreseen that event, the COVID pandemic necessarily coming into play and causing us to need to sort of evaluate our systems, our processes, scale up very quickly to support our practice and remain profitable, which I'm sure anybody that's listening to this today is going to obviously have some sort of an obligation to remain profitable in their line of business. But we really, at that point, had to challenge our current vendor on the technological front of what could they do and how rapidly could they do it to sort of pivot and flex with our needs as an organization. So the brainstorming and the sort of conceptual version of what we wanted KidzDocNow to look like was in-house. It was determined in-house by our leaders of this department of organization. We really talked extensively to our local market leaders, which was my role at the time here in North Florida, talking about what are our current needs, where are we struggling to treat patients. It wasn't necessarily even at that point that patients had to stay home. Clinicians had to stay home too at times if they had qualifying symptoms. And we wanted to see if there was a way that we could provide end-to-end care, peer-to-peer connection for a clinician and a patient who's not able to come to the office at the same time. So lots of these challenges obviously were coming up all at once. And when we were obviously in constant communication with our current vendor, bringing them our problems, asking them for solutions, we were met with what we have seen with some other vendors we do business with in other spaces of sort of like dealing with bundled box technology that's not very customizable. And that really was, at that point, a barrier for us to provide more services quickly and also deliver them sort of, here and now, not waiting days, weeks, months, or years for that sort of technology to be available to us. So we found that was a real shortcoming, obviously. Internally, within the scope of and span of our own controls, we really took what we knew and we had learned from our previous 5+ years, because we were doing telemedicine 10 years ago here at Pediatric Associates, which I think we were really trailblazers and pioneers in that space. There wasn't too many other practices doing this, but again, we're a big powerhouse practice in Florida. We have a lot of market share here, and we are a value-based care company, so we really prioritize the right care, the right delivery method, the right cost, sort of all in one package to our patients and to our payers. So telemedicine naturally, as we evolved in the value-based care world, came as sort of just a needed thing. We need to have a lower cost option for lower acuity patients to receive care now, not to interrupt their day, not require them to spend 2 or 3 hours at the office. Payer partners offering them a much lower cost solution to treating these patients, and adoption obviously sort of was good prior to the pandemic, but naturally many of our patients discovered our product through the natural course of the evolution of the pandemic, our patient access being hindered by the pandemic and patients, of course, coming into contact more and more and more with these type of influenza-like illnesses, and the obvious kind of restrictions that were put in place, where if you had anything over 100.5 temperature, a cough or a sneeze, you had to get a doctor's note to return to any type of academic or social setting that was governed by any type of COVID regulation. So really, I mean, again, we found very handcuffed and sort of held back by the technology. We were searching for someone who could kind of move with us or lead us into the future and give us some pointers, knowing that, again, telemedicine is still sort of in its it's still up and coming, I would say. There's no like playbook on how to build a telemedicine practice. There's no roadmap on how to scale it and do it the right way, because it's not really been done that many times, specifically in peds and with a practice that is anchored to a brick and mortar practice like we are at Pediatric Associates. So it's definitely unearthed some unusual challenges. And it led us into sort of the open market to look for solutions from other vendors, which of course led us to meeting eVisit.
Right. No, perfect. And it's interesting. I mean, everybody knows this. COVID springboarded. I think it accelerated the growth of telehealth, and everybody knows this, right? I mean, it just did. It forced everyone to use telehealth, and now it's an everyday thing. I mean, it's still in its infancy, but telehealth visits are not uncommon. They're very common. It happens all the time, and COVID just really just pushed it into forced us into the future, as it were.
Yeah. And one thing we've tried to sell internally, not just to our patients, but to our clinicians, is that, obviously we're talking about 5 years in the past. We're going to look probably 5 years in the future. What will we be talking about 5 years from now that we wish we were doing today? And I think we're all, we're looking at AI, and we're looking at how patients are even interacting with AI to, sort of bridge care, right? From like, what's going on with me now between when I go to a clinician, what might the diagnosis be? Is this serious enough for me to seek out care in a brick and mortar environment? And really, telemedicine lives in that nice, comfortable space in the middle, where we're almost like we're not AI per se, but, if you're going to talk to your computer, this is definitely a more reasonable way to talk to your computer or smart device about your healthcare needs, because you're actually going to talk to a human being. You're going to talk to a licensed medical professional, somebody that can actually look at your medical records and potentially, give you solutions without requiring the commitment of taking your child out of school, missing work, going and sitting in an office for 2 or 3 or 4 hours. Obviously, expenses of travel and stress of travel sometimes, but we really see ourselves as progressive in that lane. And of course, we are looking at ways to embrace AI and the potential to sort of streamline our operations and improve our care delivery and help our patients have a better overall experience that requires even less time attached to their phone to see us. We're trying to make it as least invasive as possible. And again, we've obviously spoken a lot about that, Jeff, you and me together.
We have, for sure. And I think and this is a perfect segue to our next topic, is that during COVID, you need a doctor's note to go back to work or school, or, and the push was to avoid going to the ED, the ER, right? Emergency department diversion. So many health systems are pursuing digital care innovation, and they describe the ED diversion rate as their ultimate metric. Since up to 8% of virtual encounters currently result in patients avoiding the ER, which in Pediatric Associates case represents literally thousands of patients a year. What specific protocols or priority tags do your telehealth coordinators use to identify high-risk patients before they decide to leave the queue for the hospital?
Yeah, the ER diversion is definitely our number one focal point that we use here at Enterprise Telehealth to really not only kind of focus our care into like a North Star, but also to really measure the impact that we'll have, not just again on our patients' lives, but on our payers' relationships, our contracts, everything from capitation agreements, MLR, all that type of stuff that a lot of healthcare execs are probably looking at. So the queuing that we use in KidzDocNow is actually sort of like the second or third step downstream in a process that sometimes begins with an interaction on our phone system through our organization, or maybe an encounter at an office, or maybe a message we receive for our patient portal. So we do skim at various points and try to contain costs as much as possible. Again, whether it's giving home care advice through a medical assistant or a registered nurse through our clinical advice line, or if it is, again, through a on-demand visit through KidzDocNow, where a patient will initiate care by joining our app, joining our virtual waiting room, and then being processed by a telehealth coordinator, as Jeff, you kind of outlined in the last bit of this question here. So we have available to our telehealth coordinators a list of symptoms or concerns that if they are if they're in receipt of from a patient during the screening process, that they will immediately isolate that patient, flip them into what we would call a high priority status, in which all of our clinicians are trained as they are scanning our virtual waiting rooms to immediately grab that patient if someone is available. It leapfrogs every other patient that is waiting at that moment in time, so that we can obviously make a decision of whether or not this child's care is appropriate on telemedicine, or if they need to be handed off to a higher cost option, such as an urgent care or an emergency room. And something we had talked about at length, Jeff, and not just today, but previously, we sort of bundle in emergency rooms, urgent cares, all sort of into one bucket of just a higher cost center that would obviously punish us on our capitation agreements, on our VBC models, and really not deliver any real quality improvement as far as care delivery to a patient. I think we've all heard of stories of people taking their child to the ER and they just basically get examined to ensure that they're not experiencing something life-threatening. And then they can sort of just be handed back to their PCP the next day that they're open for business. That's not good healthcare, right? Like that's great ambulatory medicine. It's great, obviously protection of life, but it's not healthcare. It's sort of delayed care, if you will. So really one of the things that we've been trying to teach our patients over the years, and I think it's really helped us grow our practice, is just sort of the 24/7, 365 operating model that we have employed as an organization, where we answer our own phones 24 hours a day. We operate KidzDocNow on demand 24 hours a day. And we suggest that our patients contact us first so that we can help them get timely care by the right folks, basically whatever fits into their life at the time. There's the times where parents are not able to get to the office, where it's 3 a.m. in the morning and everything is closed, but us, we're open. And we can often help patch together a telehealth visit and a visit that needs to be completed at a brick and mortar because perhaps labs are required or an actual physical exam is required that we don't have the technology to complete on KidzDocNow. So we are, again, as I kind of described, part of a process as enterprise telehealth, where sometimes the visit is contained and stopped with us. Sometimes it's contained before it hits us by, again, a medical assistant using our scripted screening protocols, or a registered nurse doing true triage. Or sometimes we are appropriately referring the patient to a higher cost option when their symptomology and their perhaps history warrant that. Making really, again, the ultimate sort of value-based care powerhouse that we are not just only scaling in Florida, but we are working to evolve our contracts across our organization to all be value-based care. Because really, again, that makes us, I think, really strong stewards in the entire healthcare space, not just as individuals, but as an organization where we're thinking of cost and quality in perfect sync.
Right. Yes. It's a village out there. It's a team effort. Yes. But I think one thing to highlight is, the thorough intake and nurse triage process to make sure the patients that get in are.
Yeah, I hate to oversimplify it, but it is really just we ask questions of what is the patient currently, what symptoms are you currently observing from the patient, and if any of the red flags pop up, we simply mark it high priority. It's a really simple process, and we do visit that quite frequently to make sure that the list is complete, and we update it when there's public health emergencies. We had, obviously recently we've heard of some measles cases popping up in higher concentrations where we actually do business. So we've added to protocols when that happens. So it's an organic list that we're constantly monitoring and looking to improve, just so we catch more. Because obviously, if you ask risk management, they'd rather you catch more and not need it than the other way around. So we're constantly trying to catch as much as we can. But one other note, Jeff, that I didn't touch on here, which I think is so important, is the 8% here of ER avoidance, which we at scale, we're seeing 250,000 encounters a year here in enterprise telehealth. So you just do the simple math of that, and we are really, really, really saving a significant amount of resource again, of what would otherwise be sent to an emergency room for something that's super low acuity and doesn't need to go. And when you bundle that in with our urgent care diversion, we're actually around 30%. So we are offloading about 30% of our higher cost patients from those care centers and containing them in-house. So it's a really strong model. It's something that you guys help us track, which is really important. We ask our patients, what would you do had KidzDocNow not been available? And we ask them before the visit, not after, because we found in the past a lot of them, based on the diagnosis they received, they would answer the question through that lens. But we found that asking up front would give the most honest answer. And again, we're finding that for the most part, a third of our visits or so are avoiding higher cost options, which is absolutely incredible.
It is. It's amazing. And you beat me to it, because I was about to go to that 30% number when you include urgent care and other. So then when you're talking about volume and scale, you're talking about not just thousands, you're literally talking about tens of thousands of patients who avoid urgent care or ER or ED. So speaking of scaling, another perfect segue. I appreciate that very much. So let's talk about scaling via the bunkered model. The practice has literally, it's seen remarkable growth, expanding from 7 providers in 2019 to over 90 in 2024. Can you explain the logistics of your bunkered model and how the global virtual waiting room allows a single clinician to effectively manage patient volume across multiple states like Florida, Texas, and New York?
Absolutely. So this is definitely a loaded question that you could probably do an entire hour-long in-service just talking about. So I'll do my best to keep it short and sweet and touch on all these points here. So again, naturally, I'm going to just blame COVID for sort of the acceleration of going from 7 to 90, because I want to say we probably went from probably 20 to 70 during 2020 to 2021. It was very fast. I would say that was the sort of the catalyst to the explosive growth. Again, just because based on needs, that's what popped up. We were mainly a Florida practice at that time. We had just acquired our Texas organization that we were starting to work with at that point. So we were really focused on Florida mainly during the pandemic. So that really made things simple in hindsight of what we're doing today, how simple and easy things were then. We were dealing with one state, one group of payers, one set of licenses, one time zone. Really all the things that we sort of deal with now that have turned into challenges with credentialing, with enrollment, with just, again, individual states having different rules and regulations around how telehealth can be administered, when it can be administered, supervisory setups in order to meet local and state regulations. It's become complicated. And we've sort of discovered some of those complications as we've moved from east to west now, obviously hitting Texas, and we bundled New York and obviously to our East Coast practice. But we're now really running into some of those big challenges in California and a little bit in New York as we're trying to scale that practice, because regulation is very heavy in those 2 states around telemedicine. So again, probably could do a whole hour session on that, but won't bore everybody with the granular details. But the virtual waiting room for us has been, obviously, I mentioned this before, but I'll give a little more detail. We are mainly on-demand practice. So about 80% of our visits are on demand, about 20% are scheduled, which is definitely unusual. As we've talked with you guys, talked with EMR vendors that we've made some EMR changes over the last few years. Some of them have telemedicine baked in, some don't. None of them have anything to serve on demand. It's just not, it doesn't exist. So it's definitely something we do that's very niche for us. And I have mixed emotions on whether it's the right thing to do long-term to scale with a pure on-demand model, just because it does make it very difficult to staff and to manage wait times and to be responsible with our salaries. But the technology that we have partnered with you on to create has made it possible for us to operate in an on-demand world. So the global waiting room basically allows us to have an API that goes across to our EMR vendor and move patients in between clinicians, which is nice. So we have sort of a database of clinicians through our EMR that are divided into East, West, and Central. So we have 3 EMR instances. And the integration between eVisit and Pediatric Associates allows us to sort of send the patients to the right place once they hit our global waiting rooms. So the global waiting room is kind of like a proxy user that we use. It's not an actual clinician. It drops in there. And then we have our coordinators basically look at the patient, look at the instance they dropped into, and then assign them to a clinician that has an available slot. So we have templates that our clinicians use that are regulated by a certain amount of visits per hour. And then the clinicians are then able to obviously follow their kind of just standard template like any clinician would in an office. And obviously we use that to sort of measure where we're at with wait times, where we're at with patient access. We look at fill rates, we look at all that type of stuff. So we know when it's time to add patients. I'm sorry, add clinicians. We always want to add patients, but we need to add clinicians so we can continuously add patients. So we've spent most of our time really over the last 2 years where we haven't been growing quite as aggressively because absent a pandemic, which is a good thing at the end of the day. We are obviously now looking at ways to, as we talked about earlier, use newer technology, AI, machine learning, to help us make decisions of where patients should be distributed to without needing human intervention. Human intervention is obviously a bottleneck point. We have coordinators that, they're normal humans. They call out, they're sick, they have technological issues, they have, we have surges in volume. We have some hours, we have 120, 130 patients arrive to our waiting room, and we have the next hour 50. So it would be nice if we had a little bit more technology there, but again, that's what's been nice about this partnership with eVisit is we're able to talk about that stuff, and there seems to be a pathway to unlocking those type of things. Where, like I said, with our previous vendor, we were sort of hitting the developer wall where there were no APIs available. There was not a team that was really interested in developing it beyond just a big box product. And again, that's where eVisit and us have come together, and we've made some improvements to make it possible to use a global waiting room model and then distribute patients within their own markets without obviously bloating wait times or creating friction points for the patient where they would become a customer service complainant.
You brought up, there's so many points there. I'm trying to think where I go first. One thing that you did talk a lot about, or a little bit about anyway, was managing the queue and managing the wait room. And the beauty of this is the telehealth coordinators this leads all the way back to the ultimate metric, which is ED diversion, right? Keeping patients out of the emergency department. And with a global waiting room, the telehealth coordinators can go in there and they can triage and move around and reassign and see patients quickly and assign them, as priority, as needed, I guess is what I'm getting at. So it's really the ability to scale is dependent, and it's essential that you have an efficient workflow and waiting room and so forth. So
and the nice thing about eVisit is that we've been able to use a broad approach in a market like Florida, where we are seeing upwards of 200,000 visits alone in Florida. But then we're able to compartmentalize other markets if we want, by state, by sub-region. Like, we can get as granular as we want if we want to, which has been nice. And then we can assign staff to what we would call like micro practice models. So there's so much, there's just a lot of diversity in our operating model that we can employ just based on having a platform that moves with us and has the ability to be customized down to the, operation department's needs, which is often not available with other vendors, as I mentioned. So we're definitely happy we can do that with you guys.
Yeah, and it's been quite a ride as well. But that absolutely leads me into my next topic, which is recruiting in a competitive market and combating burnout, because you're talking about the volumes that you're seeing, high volumes, multiple practices. So you've noted in the past that removing overnight calls for in-office clinicians
Mhm.
is a rare benefit in primary care. In the years since implementing eVisit, have you seen a measurable decrease in your recruitment costs or time to hire for new clinicians and nurses? And this is one of those where I do have a bonus question as well. Can you talk a
Awesome.
little bit about how you're helping clinicians avoid burnout? Also, in the past, I've heard you mention jammy time. If you could just maybe
Mhm.
expand upon that a little bit, we'd appreciate it.
Yeah.
Because the thing is, with virtual care, not just virtual care, I work from home. Many of us work from home. When you blur the line between office and work, or home and office, and work and home, and so forth, it's really easy. Burnout's real. In the past, you'd think, oh my gosh, working from home would be the easiest thing ever. But when you live and work in the same place, those lines are blurred. So what's Pediatric Associates doing to help combat that burnout,
Right.
and the training and time to hire as well? I'm sorry. Yeah.
Yeah, yeah, gotcha. So there's a lot to unpack there again. Again, we exist as an organization in a kind of a hybrid space where we have a dedicated telemedicine team that is in remote setting, work from home. Our leadership team is scattered over like 5 different states. Our clinicians live in multiple states. They hold licenses for multiple states. But we really, when we bring enterprise telehealth to a market as sort of a new feature of a market, again, as I discussed previously, there's value-based care that has to be sort of communicated, strategized around, because most of our practices that we've worked with are fee-for-service practices. They're not used to value-based care, so we really have to sort of bring ourselves into market with that kind of coeducational piece to let them understand what we're doing, why we do it, and what the ultimate goal is of adding enterprise telehealth. Um, and what we find, friction points often are moving away from that model where it's uncomfortable for them to realize that we will be seeing patients that they would otherwise be seeing in the offices, and they see that sometimes as cannibalization. They see that as again, sort of like risk to their business, risk to their practice, risk to their KPIs. And what we come back with is more data around what we talked about earlier, Jeff, like where would you have gone if KidzDocNow was not available? And we can comfortably show off the cuff that 30% of the patients would have gone somewhere else. They wouldn't even have come to us. And then about another third of the patients say they would have done nothing at all. So again, we're looking at really maybe about a third of those patients would have went to the office, but maybe they didn't necessarily need to go to the office. And some other things that they might have done would have been to make a phone call to the office and leave a message for their clinician to call them back. And when we talk about jammy time, those are the type of things that we are trying to unwind a clinician for being responsible for. Um, Under no obligation is a clinician going to be asked to call every single patient that calls them every day, right? Like I think most practices have some sort of containment model where they say, hey, we're only going to escalate things up to the clinician, ask you to call them if it's really truly something that requires your level of licensure and experience. Um, and again, when we bring enterprise telehealth into a market, we bring that layered structure that's definitely stretched more than any local brick and mortar practice can have. Because as I mentioned previously, we have medical assistants, we have LVNs, we have registered nurses, we have APPs that even sit on our team that help with inbox tasks. So we have all these layers that come before even our telehealth platform again, that we help to contain all of these additional duties that often are not billable. I mean, most of these things we talk about are non-billables. They're pain points. They're part of comprehensive and complete high quality care, but they don't necessarily need to be done by that specific clinician. So again, as we get into these markets and we start to broadcast kind of what we're going to do to help them, a lot of times we start out by sunsetting their answering service. They have a very high cost answering service that is responsible for answering their calls off 8 to 5 hours, Monday to Friday. We bring our clinical advice line team in there and we start answering those calls for them. Um, and immediately they see a reduction in call. So like any clinician that's on call that evening, the minute we implement our enterprise telehealth model, they see an immediate reduction in call because even The answering services don't have the flexibility we do. The answering services don't have access to the medical record. They don't have history on the patient. They often are not pediatric focused clinicians for the most part, as we are. So we contain these calls at a much higher rate than an answering service would, and for a much cheaper rate, by the way, I should add, than the answering services charge per call. So what does that do then? That reduces the amount of visits that sometimes go to the office. The patients are not coming in for unnecessary visits. And then again, as you go through the evolution of the VBC model, you talk about kind of beefing up panels, adding more patients to the panels, because again, we're able to offload that super low acuity stuff to enterprise telehealth and bring in patients to the office that really truly need to be seen, that need to be examined, that need diagnostics, that need treatment. And again, really provide an experience for a patient that is both convenient and high quality. Because I think the worst thing ever as a parent, I have 4 children myself, so I'm just as aware of anybody that's a parent out there listening of the struggles that is to bring your child to the office, have a 2-hour wait and be told that they basically have a runny nose, there's nothing you can do, and go home and make sure they blow their nose and hydrate and watch out for these symptoms for the next 2 to 3 days. It's a real pain point. Folks have to take off work. And like you said, Jeff, if you're not working from home, it can be challenging if you're working from home too, right? But if you're not working from home, that can be a real hardship. If you're like a teacher, you have to get coverage and then you have to pick your kid up from school. It's process, right? It's process. So again, we bring that strategy into every market we go into. So there's residual positive effects on in-market hiring for both the brick and mortar clinician, because now they're seeing the value add of having this telemedicine backbone backing up their brick and mortar practice. And then as we hire folks in enterprise telehealth, we are that work from home team. We are that virtual care team that, treats very, very tight-knit niche sort of symptomology. And we find that once clinicians start with us, they generally stay. They find it to be a very rewarding, very essential part of the healthcare space right now. And we've also found that as we implement enterprise telehealth in these markets and our sort of operating model, that the clinicians in the market also respond very positively. After there's always a little initial resistance, and that's to be expected. But once they overcome that initial resistance, there's generally like, okay, what else can you do to help us? Because this is going really well. Like, what else is in your toolkit to make our life better, to reduce the amount of jammy time, the amount of time we're spending at the office? Like, that's what we usually measure jammy time is, like, it's time after our work. So after whatever your scheduled contracted hours are, that you are either stuck at the office or at home doing post care, like doing phone calls, signing lab results, et cetera, et cetera. So we try to exist again as a telemedicine product to reduce that amount of jammy time. Again, offer convenience to the patients, offer value to our payer partners, and really be as progressive as we can in the VBC world. And I think we've been pretty successful at that. But as I said earlier, we've got a long way to go. We've only got Florida and Texas covered 24/7, and we have, Jeff, as you know, you've got our full roadmap in your possession. We've still got a long way to go to cover our entire enterprise.
Yeah, I love that. The thing is like there's a place for brick and mortar and there's a place for telehealth, and they can and should work together. It shouldn't necessarily be a competition, and it's really not. And I love it when a practice or an organization sees the value of that and is able to reconcile the place for both. Then when you throw the Pediatric Associate structure behind it and the support behind it, it will lead to inevitable combating burnout, because you have that support, you have that extra support. So it's really some great points to point out. Moving on to the last, but certainly not least, we've been talking very not high level. I mean, high level, yes, big topics. Although you have touched on some specific points, but let's talk a little bit about recouping left without being seen. This is a very specific initiative that Pediatric Associates has and has been doing for some time now, but scaling from 70 to over 190 staff and providers using the bunkered models, it's a massive jump. It's amazing. It's really exciting to talk about. When you look at your left without being seen and missed appointment data, how much of that success do you attribute to having a virtual overflow valve that catches patients before maybe they head to the ED or reach out to different providers. And Greg, I know I've been on with Pediatric Associates working with you all for a little while now, and this has been a major initiative here. So I'm excited to hear what you have to say about this. Maybe I've heard most of it before, but I doubt I have. But I'm excited to hear what you have to expand upon this question in this area.
Yeah, so left without being seen is definitely it's a pain point for anybody. When I was in brick and mortar practice management, this would be basically identified as someone that came in, checked in, and then left without being seen. And I think anyone who's ever managed a medical practice knows that is like that's the worst outcome that you could have for someone that schedules an appointment, and you can almost expect a negative review from that. It takes a lot for someone at a brick and mortar to usually pick up and leave. Like they've really gone through a lot of extended waits, it could be, not meeting their expectations, could be a child that, appears maybe a little bit less content waiting in the office for long periods of time. I have a 4-year-old, that would probably be him. You can only do so much to keep them contained and happy. But telehealth, it seems that from what we've uncovered so far on this short but educational journey we've been on for the last few months, we're working with our service recovery team, is that people are a lot less flagrant about leaving a virtual care environment. Like they'll just leave. Like they have again, there's no relationship with the office. There's no relationship with the clinician. There's no relationship really with anything other than their cell phone, because most of our visits happen through a phone. And they're very quick to just say, never mind, I'll try something later, I'll go to the emergency room, this is taking too long, which is a real head scratcher because, again, there's really no quicker delivery option than using virtual care. So a lot of the challenges that we have as an organization, I explained earlier, were about the fact that we're on demand. If we were scheduled, this would be a little bit easier to guardrail. You'd have, clinicians kind of with an expected visits per hour, and their templates would be conductive of that. And we'd have obviously some checks and balances in place to ensure that if there was no shows or something, that we backfill visits. But again, in a pure on-demand model, I described earlier, we have at times 150 patients an hour arrive, and we have 20 clinicians staffed. And we at that point we don't have a good way of identifying that as it's happening, other than we see the waiting room getting really, really busy all of a sudden and the list getting really, really long of patients. Our leads will often call that out when they see that happening. And we will, at that point, attempt to maybe schedule some folks for future times, because we can still schedule appointments. Like we can absolutely do that. The patients, we call ourselves KidzDocNow, not KidzDocLater. Try to take care of them now. So the service recovery team that we have designed and started to study their impacts was a project that began in December of this last year. We have a few professionals that their role is simply to monitor what we call the missed visit tab. That is an eVisit feature. And it gives us sort of a task list to follow, where we have the patient's name, we have their contact information, we have the amount of time they left, we have sort of like when they left, how long they were waiting when they left. And then we start a cadence of outreach that is both digital and physical. So we do some text messaging, we do some phone calls, and then we capture data around that to really try to understand why they left, what levers we can pull on to improve that, how we can recover that visit. And again, like you said, Jeff, ultimately keep them from going into an emergency room or a higher cost option, which, as I said before, it's not all about cost, it's about quality. This is not necessarily going to be a high quality outcome, even going to the emergency room, because again, the majority of things that we treat on KidzDocNow they're just low acuity things. They're stuff that we can resolve in enterprise telehealth. They don't require a visit to the emergency room. So that team right now, we're currently working with a couple individuals and our manager of our patient intake to really study the impacts of this. We are only doing this in Texas right now. We are looking to bring this into our Florida market soon. But our Texas market's about a fifth to a sixth of the volume of Florida, so it's much easier to run proof of concept there and things like that before scaling it up into our Florida operations. And what we found so far is that we're effectively able to make contact with about 60 to 70% of the people who leave. And then we have just, again, variable data points showing why they left, what we can do to do better next time. And again, ultimately, we're finding that the majority of those patients, we are able to recover them to some degree. But we are actually sort of coining all of our efforts right now, protection, like visit protection more than recovery. Just because for it to truly be recovery, I think we need to get a little bit higher up into the numbers of as a percent of recovered visits. 70% is okay. We like to get close to 80 or 90. But we are still making outreach calls to all these folks to learn how to better protect these visits from leaving in the first place. So that's really the ultimate goal of this is to recover and protect the visit from leaving in the first place, and then having, like you said, a valve that we can use to recover them if needed. So
Yeah, I
that's where
love
we're
that.
at right now, point in time on that, and it's been successful so far. Um, but again, not without challenges, as most new processes bring to light.
Yeah, I would never dream of leaving in a brick and mortar in office visit. I don't think, I mean, unless something very dramatic came up and something happened, and I couldn't imagine walking out. And then there's no, for those who do, and I think the percentage is probably pretty low. It's not
Yeah.
like the receptionist or a nurse is chasing the person down the street to figure out why did they leave. The beauty of the telehealth instance is, one, it's convenient, as we all know, but also we can get really good data around why people are leaving. But also there is that aspect of, I'm online. I can just close this browser. I don't need to be here anymore for whatever
Yeah,
reason. But with
yeah,
service
yeah.
recovery, you can find out, was it technical? Was it maybe the baby was hungry or had to go back to work or something? You get this data that you can really act on. And I think that's what we've been doing. I know,
Yeah.
working with you and the recovery team, and it's been so insightful to try to figure out why people are
So
leaving.
something interesting I'll share along these lines, which I think is kind of fun to talk about and also an interesting point to make. So when I was in my brick and mortar practice, we would receive data on sort of which clinicians had the worst no-show rates and which clinicians had the best show rates in the practices. And there was always one clinician that we swore was, and probably was carved out as a data anomaly, that had like a 99% show rate. And everybody else, even our top performers, was in the 85, 90% range, but this one was just significantly higher. And eventually it caused for us to make a phone call and be like, what's going on? Why are your patients so compliant? And she basically explained to us, she's like, oh, if I see that they no show to visit when they come in for their next visit, I find out why and I talk to them about it. And she didn't use the word necessarily accountable, but she was like, I wanted to learn why my patients weren't showing up. What is it? What's going on? But she sort of stopped on the fact that, like, because I brought it up and held them accountable, that is the main reason why they stopped doing it. So the fallback of all of these different things that we're going to try within the service recovery team, which is of course like trying to find out, is it application friction, is it communication friction, is it wait time, like what is it, why they're really leaving, but just the mechanism of calling the patient after they left, and again having that sort of little bit of accountability, I think naturally will make patients stick around if they've had that experience. They're not going to leave and be like, oh, I don't want them to start calling me again. I'm just going to stick it out a little longer. Because, I mean, Jeff, we've looked at this data together. We have people that leave under 5 minutes. They leave instantly. And it's like, we don't really know why. They've gone through check-in. They've come to see us. They've shown that there's symptomology that's consistent in the telemedicine visit, and they leave. And if they had waited maybe 5 more minutes, we would have had them seeing a clinician. But I thought that was an interesting story to share, just because, in a big practice like ours, a lot of the clinicians don't want to get involved at that level. They don't want to have those type of conversations. They feel that's administrative. They feel that's practice managerial. But our clinician very firmly stated that, having that conversation, caring enough to find out, like, are you having trouble with transportation? I mean, we find social barriers this way as well, that we sometimes need to help them address. We do have quite a bit of Medicaid in our practice, so that social barriers exist, and we do have great resources for them as well. And telehealth is a great resource, obviously naturally, but we have other resources that we engage in those cases. But ultimately, again, there has to be a way to recapture these visits, these folks that leave, learn why they're leaving, take appropriate action to correct it. And I think ultimately at the end of the day, it proves that you care. It proves that you showed up to the practice, that you said, my kid is sick, and like we realized that we weren't able to deliver the service, and we care enough to ask you if we can recover you and make right the second time around. Even again, if they left under 60 seconds of wait, which I don't know many places that you would go and be served within 60 seconds or less, but we still want to learn from that experience and do better and meet their expectations in the future. So it's been a good learning experience so far. We have a long way to go, as with most things. But again, the missed visit tab has been great to help us identify, compartmentalize, and then task assign that to a coordinator or recovery specialist for processing.
Well, yeah, and you said you hit on a point that I really think about a lot, is that you care. You want to make sure they're okay. Is everything all right? I always love the best experiences I've ever had, and just with brick and mortar or others, when somebody would, after a visit, someone would follow up. Just say, hey, Jeff, how you doing? Is everything all right? Are you good? I am. Thank you so much for calling. It goes such a long way. It really means a lot.
Agreed.
And that's what we're all here for. Really, that's the whole thing.
So
we covered a lot of ground today. Before I wrap this up, Greg, any final closing thoughts before we shut it down?
That's another one we could probably do a 60-minute in session just on that. But one thing, I've learned just being in this role for the last couple of years, and prior to that, technology is either your best friend or your worst enemy. But if you're not constantly challenging your technology to get better, you're going to be stuck, right? You're going to be stuck where you're at. If you're not growing, you're dying. It's one of those type things. So you got to continue to grow your technology. You got to keep pace. You got to set the pace. I think, Jeff, you and Nate, obviously, we talked a lot about this. Like, we really try to push the technological envelope to where we're told, no, like, we can't do that. That's, I think, when you're operating at a really healthy level, is when you're going to vendors and you're going to your partners and they're like, we can't do that yet, but we're going to look into it. Like, that's the type of relationship you should have as a leader. If you're in a healthcare organization and you're partnered with technology, and really there is no other medical practice that's more technological dependent than virtual care systems like the KidzDocNow app and the Pediatric Associate family of companies. So our relationship with you guys is existential, and the development of our technology and our tools is going to have to continue to advance at the speed of light. And again, I like bringing things up and you tell me no, and I see you writing everything down and you bringing it up to the brilliant people that develop this stuff and write that code. And it's so nice, again, when we circle back and we see some of these things coming to reality in eVisit product releases, which we have a couple coming up soon that we've been talking about for a while. So very exciting.
I appreciate that. Yeah, being challenged. That's what it's all about, because it's a constantly moving. They keep moving the goal line on us, is what happens, and that's what's going to continue to happen. And I love it. It's exciting. So.
Yep.
I want to thank you, Greg, for joining. It was a great discussion. Like I said, we covered a ton of ground, but it was a pleasure highlighting all of the great things Pediatric Associates has done with KidzDocNow. And I really do look forward to seeing what comes in the future, which, I mean, I'll be a part of, because we talk about it every single week, which is really exciting. So thanks again. And thanks everybody for joining. Really appreciate it. Have a great day.